Live from New York, it's the 11th annual Mega Gen Convention, and I am so honored that you joined me. The reason I wanted to bring Isaac on, Isaac Tawil, right, is Isaac, you graduated in what, 2003?
That's correct.
And this is 2015, and right there on my podcast series, there's probably gonna maybe 1,000 people will see this on Dental Town, maybe about 300 on YouTube, but 2,500 are listening to this on iTunes, and they're driving to work. And my question to you is, next month, 5,000 American kids are going to graduate from 56 dental schools, and you and I both know that in their entire career, 9 out of 10 are never going to place a single implant. So what I want to capture with you is, why did you... because you're not a periodontist or an oral surgeon, you're a general dentist like me. How did your journey start to where one day, not only did you place an implant, you placed thousands of implants? And what advice would you give to that, or even a dentist who's been out of school 10 years, who's never placed one spell out a stair step? How could they someday be like you?
Well, that's a great question. I have to say that when I was in dental school, I had a wonderful dean by the name of Michael Alfano, and he drove in a message to us that stood with me for the rest of my life. He said, "You are not dentists. You are all physicians. You have to look at the mouth and treat it as a whole." And so immediately when I graduated, I started doing that. And I knew once I graduated, I didn't have enough information. Whatever I learned in dental school was a great foundation, but it did not take me to the level that I needed to treat people as a whole and become a true oral physician. So in my journeys, I had found several patients that required much more than just composites or root canals or dentures. And I started with implant dentistry back then, replacing single teeth, multiple teeth, and it grew from there. Education was paramount, taking lots of CE courses in various different fields, but the one that really interested me the most was implant dentistry. It was more involved. It made me feel as if I was treating the body as a whole and not just treating just an isolated area. You know, with implant dentistry comes a lot of systemic factors.
What is implant dentistry? You talking about a course, a magazine?
No, I mean implant dentistry as a whole. As okay. You know, treating people, placing implants, diagnosing.
How did you get the information to place your first one?
So initially, I was just taking local courses in the area of what I may like. Maybe a local oral surgeon was giving a class on implants, and it was really more driven toward restorative, but they showed some surgical slides. Then that piqued my interest, and I started looking for some local courses, again, that would teach more of the surgical aspect. I started out with Zimmer implants, and they took me out all the way to Carlsbad, California, and we were practicing on a mannequin. And that was
Zimmer a mini implant?
That was the full implant, the regular TSV, tapered screw vent designed implant. And we had been placing it on a mannequin, and everyone's mannequin, they wanted you to hit the nerve, and I hit the nerve, but mine didn't beep. Everybody else's beeped. So I said from there, I said, okay, I got to make mine beep. And I kept going to courses until I did make mine beep. So we went from one to another and through various educators like Arun Garg and Samuel Lee and other courses that I've taken, cadaver courses, going through organizations such as ICOI, AAID, and taking their courses, their seminars, and for example, like being here today at the 11th Annual Mega Gen Symposium. I've been to a bunch of these now, and every time I come, you learn something new.
Okay, so you mentioned Aaron Garg, that was a hands-on course.
Correct.
Did you recommend a hands-on course?
I love hands-on courses. I think the best way...
No, describe a hands-on. You mean hands-on because there's hands-on on a model,
right.
There's hands-on on patient.
So I think the best way is to start with a model. Just plain and simple. This is how we do it. This is where we drill. This is where the neighboring teeth are. This is where your implant should go. Once you've had some of the didactic information, even you can get reading a book. Reading Carl Misch's book, you can get enough didactic information to then go ahead and start doing model-based dentistry. And then from there, I think cadaver courses are generally the best course because, again, it's similar to a human being. It's not live. It won't talk back to you, although some, I think, did. But, but for the most part, you're now working on something that's live. That's real. That's real. And then the next step from that is to go ahead and start doing them through the actual live surgical courses. We offer one in Mexico where people can come and place implants on live people. There are several of them throughout Vistara in New Jersey, Dr. Elian's course. We do a mentorship program where we hold your hand and teach you how to place them on live.
You do that
meetings.
yourself?
Correct.
You do a hands-on course?
Correct. Well, through Dr. Elian, Nicholas Elian in Vistara.
Oh, and how do they get information on that? www.
So yeah, it's on the CDE website, I believe.
CDE?
CDE World, right? CDEworld.com.
CDworld.com?
CDEworld.
CDEworld.com. Okay.
And you can find Dr. Elian's mentorship program on there, as well as other hands-on courses that are offered.
Okay, so I'm going to stop back. A lot of times we start giving instructions of like, how do you drive from LA to Phoenix? And a lot of people are thinking, well, why the hell do I want to go to Phoenix? I want you to first start with these 9 out of 10 dentists listening who have never placed an implant. Tell them why they should add placing an implant to their curriculum.
Well, I think first you need to actually like to do surgery. If you're not into doing surgery, you at least have to know how to diagnose it and refer it out to the right people who do. But once you have a feel for it and you like it, you're not afraid of blood, you're not afraid to go into the little nitty-gritty areas of the mouth that some other people might not find, that might not like to do that. But once you're into that mode...
Well, let me stop you right there. So a lot of people think only 5% of general dentists place an implant. Would you compare it to what type of extract? You said you got to like blood. So then I want to ask you, what percent of general dentists you think like blood and pull teeth? And how good of a situation of pulling a tooth would you have to be, do you say, to place the implant? I mean, what if someone says, yeah, I'll pull incisors with gum disease for an immediate denture, but I won't pull a wisdom tooth? Tell them what similar exodontist skill set would qualify you to place
that's a really great question. That's a really, really good question, because for the most part, those periodontally diseased anterior teeth, you can have your kids take those out. So that's a big discrepancy between that and doing impacted wisdom teeth. So I would say if you're the type of dentist that your orthodontist wants to do serial extraction and pull 4 premolars, whether you agree with that or not is a totally different topic. But if you can take out those premolars, you can certainly go into the field of implant dentistry.
And what percent of general dentists you think could take out those 4 first
I would say if you're coming out of dental school, I would say at least 75% of dentists would be able to do that with ease.
Which really means 75% of dentists, 3 out of 4 dentists
should be placing implants.
I understand, I get it if you say, I don't ever want to take an upper denture and place 6 implants in a bar, and that's surgeon prosthodontist stuff. I get that. But 95% of the crowns that go into the labs are just 1 unit at a time. Mm-hmm. And 95% of the implants are just 1 tooth at a time.
That's correct.
Yeah. And we agree that 3 out of 4 dentists could do those.
Absolutely.
So then I want to So now that we got that, I want to ask you this: in order to do that, do I have to buy a $100,000 3D X-ray machine, CBCT? Did you buy one? Is that kind of a prerequisite to be a quality? Well, placing single tooth
I think
implants?
I'm the wrong guy to ask that question, because I'll have like an Apple Watch in just a couple of days. I'm that techie guy that loves to have all the toys. So for me, I like to have that, and I think there's enough value in it to have it. But you don't necessarily have to have one in your office, but you can have access to one. There's so many centers all over, and it's not just for implant dentistry. Cone beam technology for endodontics, for general dentistry as a whole is becoming more necessary. We're looking at treating the whole mouth, not just one area, or we're looking to look inside without actually having to go inside the mouth.
Now, do you do root canals too?
Absolutely.
Because do you agree or disagree with the statement that the #1 cause of a failed root canal is not cleaning and shaping? It's they missed a canal.
Oh, absolutely.
An MB2 in the maxillary fourth molar, a mandibular second molar. The disc canal is 2, not sometimes 1. A lot of lingual canals in the incisor.
Even in the anteriors, yeah.
So do you use your CBCT for root canals and implantology, or is that or is the best CBCT for a root canal not really the best one for implantology?
So I think that's where skill set comes in. So if you're an accomplished general dentist or someone who's performed many root canals and has great success over the years, then I think your standard protocol would work fine, because you would know when you might require a CBCT. You would say, that root looks funny, or I see how that canal, it's really thick, but then all of a sudden it gets really tiny, might diverge. So that's the type of case I would say, great, go get the CBCT. But if you're a young up-and-coming dentist that is not really sure as to how many canals there are, but you want to treat in your office, I don't find it to be harmful. I think if anything, you're saving your patient from possible infection down the road to take a small little 3x3 or 5x5 scan of that tooth to make sure you're doing the right job. And I think we always say we don't want to do any harm to our patients. What's the better way of not doing harm than you being able to diagnose things correctly?
I've heard some CBCTs can't get small enough to find an MB2.
So I think as a young clinician, you have to start out by buying the right type of machine. Just like there's many different cars. You can drive a Hyundai, you can drive a Corvette. You know, there are different levels of cars and there are different levels of cone beam units. The most common cone beams now, though, are having various fields of view, multi-fields of view. So the one I have goes from a 17x13 all the way down to a 5x5.
And what name brand is that?
I have the Carestream 9300.
So is it true the difference between men and boys are the price of their toys? Was this a toy for you, or is this
well, it's my third one, so
it's your third one?
I go through a lot of toys, but I found it to be not a toy. It's probably one of the most important parts of my practice, and if you're thinking that you can't afford it, you're wrong, because you'll pay that monthly bill off very, very easily just with the amount of work that you're going through.
And are you billing now? Will Delta cover a CBCT, or are you billing
so we're
out
starting
like a
to see
Pano?
we're starting to see more insurance companies start to pay for them. They're few and far between, but they are starting to come around. Some companies will pay for the reconstruction version as a Pano, as a Panorex. So we're starting to see that they're getting there, just like they're starting to get there with implants as well. They're starting to pay for not just the crown but the body of the implant.
I'm going to tie you down on specifics again. When would you take a CBCT on a tooth before you did a molar? Before you did a root canal?
For a root canal.
I mean, because sometimes there's missed canals on incisors. I mean,
so I find for myself, upper molars, if I don't see a fourth canal, I'm going to take a cone beam, because I know how often there is a fourth canal, and I've missed some in my early days of my career, and I don't want to miss another one. So if I see that and then I go inside and I don't see a canal, I would immediately get the patient up, go in the other room, have the scan done, which is one of the great assets of having one in your office. You don't have to send them out into a mobile or get a mobile van to come over. You can do it right then and there and continue the treatment.
Okay, let's say, let me flip this around. Let's say a patient came in and they had a failed root canal, and the canals were found. I mean, it was a maxillary molar, and there were 4. You can see 4 got a purchase in there, and it was done 10 years ago, and it's failed. You could retreat a root canal. You could do an implant. How is your mind looking at that? Are you looking at that saying, I bet the person who did this probably did a great job, it just didn't work, it's just easier to pull this thing and go with an implant, or would you do the retreat?
So I always find that implants are a great backup. I think there's nothing beats a natural tooth in the mouth. I'd always rather have, if it was my mouth, I'd rather have my own natural tooth. If the crown root ratio was favorable, if there's enough remaining that part of the tooth structure and the other parameters fall into the proper methodologies that we currently use to retreat. If we find that there's like a J-shaped radiolucency, which is symptomatic of a fracture, or if we're getting
Explain that again. A J-shaped.
So there's lots of different ways to diagnose fractures of teeth, and one thing is one obvious one, whereas we see almost a J-shaped black radiolucency at the tip of the tooth, at the apex of the tooth. When we see that J-shaped radiolucency, we immediately think fracture. That's the first thing.
And why are you thinking it's a J shape, and why do you think that happens?
So the typical periapical pathosis will be in a ball shape at the end of the apex. However, if it seems like it's extending from the root higher up along the root in a similar fashion like a J going to the apex, that usually means that there's something there. It's either a lateral canal, which would be quite rare to cause such a big pathology, or it would be a fracture, because it would be the fracture would be higher up along the root, and then it would be extending down into that apical region.
And any teeth more likely to be fractured? Failed from
yeah,
fracture?
Sure. You see these teeth with really large posts in them, or cast posts in them over the years, metal posts, screw posts that really don't bend or flex too much, not like the modern ones that we're using now. Those tend to happen a lot. Or if you see a tooth that really didn't have a lot of crown above it left, and it was really beaten down, and those type of teeth with big, large posts in them, you know that the post is doing most of the work. that's a red flag.
Okay, so I'm going to now say that now you're looking at that. It's tooth number 3. You determined it's a failed root canal. It's from a fracture. How's your mind work now? Would you pull that and immediately place an implant? Or would you pull the tooth and graft it and go back later? Talk about what you would do.
Well, you got full of great questions. I mean, that's a topic that you can go on for hours about, whether or not to extract and graft at the same time, or to place the immediate implant, or even to put the crown on top of that same tooth. The technology has changed, the science has changed, the studies have proven that if we can place an implant at the same time, if the conditions are correct, then we should place the implant at the same time and try to get that stability. Why? Because now the patient is not without teeth for that long. The longer a patient is without a tooth, the more chance there is for shifting. And if you're not putting the proper type of retention devices to stop shifting of the mouth, then your occlusions are going to get off at some point. And that harmony in the body is very important. You know, if your back's not feeling so good and you're just a little bit off on one side and you start favoring the other leg, your leg is going to hurt you a lot. So if you're just chewing on the left side of your mouth because you're missing tooth number 3 on the right side of your mouth, then your left side can suffer a bit. So the sooner you can get a tooth back in the mouth, the better. And the sooner we can get them chewing on that tooth and back into the harmony of the body, the better. As well as what it's shown studies-wise to preserve the gingival health, the gingival tissue, the interproximal papilla, retaining those by placing the implant immediately. So there's been a lot of benefits to placing them at the same time. That being said, if you don't like the looks of the house, get out of the house before it falls down on you. So there's times when you should say, look, the architecture here is not ideal for me to place an implant at the same time. Let me graft this, come back when it's more solid, a more good area where I can go ahead and then place an implant.
Okay, but how many implants have you placed? Thousands.
I placed, a few thousand implants.
Yeah, okay, so be more specific on what that house looks like that you don't want to put an implant in. I mean,
so the house is on fire, right? Not a great place to run into. So if you see a lot of pus coming out and you can't control that, then I wouldn't even feed it with a graft. I'd say, let's clean it up as best as we can. It's real messy in there. I can't really see what I'm doing. Let me close it up.
Would you put them on antibiotic too?
Always, I like to place patients on antibiotics.
Which
be safe
one?
than sorry. Amoxicillin seems to be the best antibiotic.
Okay. So if there was a lot of pus, what if it was just bled a lot? What if just a lot of bleeding with it?
And then you want to look into the systemic history of the patient. Well, even from before that, you would have looked into their systemic history, but you want to make sure that patient's not on a blood thinner or they're not taking a lot of aspirin. And if they're not, and it's just really messy and you can't see, and then we can always control hemostasis with vasoconstrictors, a little more epinephrine if we have to, if the patient can handle not adverse to getting a little more epinephrine in their body. But I think as a whole, if you see a lot of granulation tissue and just completely blown out, there's no buccal plate, you can see the root of the next tooth next to it, just doesn't look like a good area. I mean, you might be able to get an implant to hang on to one wall, but if I'm hanging off a building, I don't want to be holding on with one hand. I want 2 hands.
Okay, so if it was pussy and bloody and all that stuff, you get the tooth out, put them on amoxicillin, and send them home.
Right.
When would they come back? Well, how long would they come back?
Just a few weeks later, I would try to get them back. I'd be about 4 weeks, I would say.
Okay, and then what would you do next? Would you do a bone graft and implant? Or
I would try to. If I can, I would definitely try to. There's lots of different devices that we have. I mean, there's a really nice device upstairs called a iGen membrane, which is a titanium mesh membrane that locks onto an implant to rebuild the buccal plate. It gives you the ideal parameters. So if you can build it the ideal way, the way you would want it in your mouth, and you believe that you would do this on your own mouth, then I would say that's a good opportunity to go ahead and place an implant. If you feel that it's better to first re-architect the area, get the construction area, foundation proper, get your right walls, and then that might be a better time, then I would wait. And I think that's really as a user dependent. If you're comfortable doing that, then you should do it. If you're not comfortable and you really don't have a lot of experience rebuilding bone, then rebuild it first and come back and place it later. But if you know you can rebuild that bone and get the implant in at the same time, then by all means, let's get them teeth.
Let me pin you down specific. Bone grafting and placing implants. What % of implants placed? And we're not talking about the complex 4 or 6 in a jaw to do a big fix to remove. I'm talking about the low-hanging fruit, the 9 out of 10 implants, just like the 9 out of 10 crowns that go to the lab, 1 crown at a time. The 9 out of 10 implants, 1 tooth at a time. What's the low? I'm trying to locate 9 out of 10 dentists haven't placed an implant. What would be the low-hanging fruit first implant selection case to look at too? That would be a 1 implant without a bone grafting. And then talk about if you do 100 implants, what percent of them are bone grafting? I'm trying to explain how closely correlated is bone grafting to placing implants.
I think they go hand in hand at this point.
I mean, do all your implants have bone grafting with it?
When there's enough bone, we obviously don't have to place more. But for the most cases, if people have been edentulated for a long period of time and they've been wearing a denture, then it's usually that we're going to have to place some sort of bone grafting material in the area. If they recently had a tooth out and it was maybe only 6 months ago and it was an emergency and they were in Cancun, Mexico, and they got a tooth taken out as an emergency and they formed a good blood clot and the bone reformed on its own, we don't need to go ahead and place a bone graft.
Okay, so
mini implants also. There's lots of that.
Put bone grafts aside. Key in on what would be a good entry level case to place your first implant. You're not a bone grafter. What should this young dentist or a dentist, maybe he's out there in the plains. His practice has been flat for 10 years, and he wants to add another surgical procedure. Go to the next level. I'm a big fan of it because I firmly believe. I'll tell you why I'm a fan of this. Doing this for 20 years, I can tell you hands down that whenever you find dentists in group practice, they're always happier than the solo guy. Whenever you find someone burned out, fried, drinking Listerine at work, eating Vicodin, he's always a solo practicing dentist fried. You go into a group practice and in between patients you go back there and feed each other.
Right.
And so group practice is better for mental health and then that affects your patient's dental health. But another thing is when you're burned out and fried, dude, all you do is fillings and crowns and you've been doing them for 8 gazillion years. Learn something new. And it seems like whenever I can motivate a kid to go into the playground, like Dennis asked me, well, should I get a laser? And I'll say, a laser can stand for losing all savings equals reality, and it can stand for light amplification, stimulation, emission, radiation. The determining factor to get a laser or not, if it makes you run 20 red lights on the way to work, by God, you gotta buy one. And you call it a toy. So, I want a lot of dentists to just start dabbling because it just reignites their fire. So I'm asking you, describe a case where the dentist say, okay, I'm scared. I have fear, but describe a case where, like you talked about the orthodontic extraction. Like, what would be the best cherry-picked first case to place your first implant?
So I think cases that have been either grafted in the past by somebody else and the patient maybe didn't want to place an implant, or you've had a patient for a while and they're just sitting there with that big parking lot worth of space and you're saying to yourself, wow, that looks really easy to go ahead, the bone looks really good, maybe you've done some diagnostic workup, maybe took a cone beam and you can see that everything looks good there. There is no such thing as a simple implant because there's always something to look for. So once you know your anatomy and you know where everything has to be, if you can find a nice block of bone that's like 10, 11 millimeters wide to go place an implant in a molar region where no one's going to see it right away, that's one of those cherry-picked cases. A lot of the cases where people have deciduous first molars still there, those are great cases because those are taking the space up. Maybe now that tooth's been decayed out and you can just extract it.
You're talking about a baby tooth.
Baby tooth.
A baby tooth second molar.
Yeah. If you can have a case like that, those are my favorite because it's good natural bone.
That's interesting. So your mind went to the tooth that's been missing for a while.
Right.
What about a tooth you have to extract because it was a root canal buildup, post crown, whatever. You had to pull that. Is that not really an easy?
So I find those to be quite simple, but I think after you've placed a bunch of implants, because drills can skip around in the mouth, and if you're going to follow the same direction where that tooth was taken out, that might not be the right direction. You might have to have really redirected that implant. So and often, I would say almost 90% of the cases, you're not putting the implant exactly where that previous tooth was. You're placing it either more lingual or more palatal to where that was. So those, even though they seem very simple, could actually be a little bit tricky. But that being said, with all that you said, I think if you can get yourself a surgical guide and you can get a nice area bone, and you can just drill through a hole and feel comfortable, and you know when you're doing the right thing. Do your checks, your basic x-ray checks, your pilot hole checks. You develop a comfort, and you develop this excitement. There's something that's new inside, and you say to yourself, wow, there's a whole world here for me. And it starts with just one implant, but it may end up where you're doing a whole mouth of bone grafting and sinus lifting and placing, 8 to 10 implants. So it starts out small, but there's a whole new world that general dentists haven't been seeing. And there's so many places to get the education on this. It's really foolish not to if you enjoy even just a little bit. I'm sure once you got into it, you'll enjoy it tenfold more. And for me, it was the best decision I ever made. I went from being one of those guys that might have wanted to jump out of the building that you showed in your lecture to falling absolutely passionately in love with dentistry as a whole. I love doing a Class 2 composite now. I used to hate it, but I love it. Why? Because 2 patients before that, I might have been placing 4 or 5 implants. And now I come to that Class 2 and I make that tooth look really good. It's about quality. It's about having fun. And it just really can change your life. And as a general dentist, we are so lucky. The periodontists and the surgeons, they're stuck doing the same thing all the time. And it's over and over again. We have this really bizarre way. We have a whole arsenal of materials. We have a book from Henry Schein or Patterson or Benko this big that we can order from, and we can do so many things. We can place posts, we can make crowns, we can scan the mouth, we can take cone beams, and we can place implants. And if you really, really get comfortable with it, it becomes the most passionate part of your practice.
You said something I want you to elaborate on. You said surgical guide. When we're talking about a one tooth, do you need a surgical guide for one tooth, or do you use a surgical guide for one tooth? Or?
Personally, for myself, no. However, if I was starting out, and when I did start out, I did.
So so if you're just starting, is it say the first 100 implants you place?
I think I did more than the first 100 were completely guided. Completely guided. I couldn't let go. I needed that person holding my hand. And when there wasn't someone over my shoulder, like we have at Vistara, where we're actually sitting there watching over your shoulder, when I didn't have that person with me, I needed someone else to hold my hand. So my surgical guide was that person holding my hand.
I just want to thank you for taking time out of your day and doing this podcast. It's been an honor and a privilege to interview you.
Thank you.
Thank you so much for your time.
Thank you.